welcome to the Connecting for Sexual Health, the CT-STI Clinical Management Series. My name is Dr. Amit Achra. I work at Yale School of Medicine as a faculty in infectious disease and also closely collaborate with CT and MA DPH. It is indeed our pleasure to welcome you all to this series. This is the second of the STI Clinical Management Series. The first one was on syphilis. Today's topic is on congenital syphilis. The series is planned by the CT Department of Public Health, the STD Control Program, as well as the Sylvia Rattel STD HIV Prevention Training Center. As you hopefully know by now, we are planning to meet every Thursday for the rest of the month of May, and this is second in the line, as we said. And this series is one of the many educational initiatives we have planned in response to the rising STI epidemic, which is both local and global. And we hope this educational initiative will improve your knowledge and confidence in handling common STI cases, as well as presenting in all kinds of clinical settings, as well as know which resources to tap into if you are in a bind. Housekeeping, as a reminder, you may type in your questions in the chat box, or you can raise your hand, although we would prefer to address them at the end of the talk, but you can certainly type them anytime. The CME details will be presented at the end of this presentation, and the link will be given to you to proceed on getting the CME. Finally, before we begin, I also want to remind people of this excellent resource. Let me advance my slide here. Oops. stdccn.org. So again, if you are a clinician in a setting where you don't have any expert advice available and you're entertaining any question about a STD or STI diagnosis, treatment, literally anything, this is a CDC sponsored platform where you can type in your question and expert review panel will review it and get back to you very soon, sometimes even within 24 hours to give you some advice on how to proceed. So please do make use of this resource and don't feel alone when you are dealing with STIs. Very good. And with that, I will stop my share and I will introduce the first speaker. As I said, the topic is congenital syphilis, and we really have an exciting lineup. First is Arlene Lewis, who has a background in nursing as well as a master's degree in from University of Phoenix. And she's here in the role of as a public health services manager for CT Department of Health STD unit. And she's very passionate about working for STDs as well as for people with HIV and has won several awards in that area. And she's been a tremendous resource for us as well to give us on the ground situation of syphilis pandemic as it's rolling out. She will introduce the following speaker, Carlos, who's a disease intervention specialist, and then finally the Professor Ian Michelow. So Arlene, you can share your slides and proceed. Yeah, I will monitor the chat. Hopefully people will participate and we can see your slide, Arlene. That's good, but you're muted.
Good day, everyone. Today, thank you for being here for this training. Today, I'll be speaking on the disease intervention specialists, whom we refer to as DIS, and their collaboration with a community healthcare provider. And I will also briefly speak of their role within Connecticut Department of Public Health. Next slide, please. So, who are the Connecticut Department of Public Health disease intervention specialists, whom I'll be referring to as DIS? These are highly trained staff. They specialize in public health investigation. They are specially skilled in interviewing, counseling, educating, referring clients, patients for treatment. They also work to rapidly identify people who may not know that they may be infected or exposed to STD, mainly HIV or syphilis. So in this situation, here we have these staff. The community provider may receive a result may have a result of a patient newly diagnosed with acute HIV or syphilis. They required some They required some assistance relocating these people. So here we have the specially highly DIS who will be of assistance. There are times they may be able to locate, and there may times they may not be successful. They also, during their interaction with these clients within the community, some of them may not have access to care when they interview these folks. So they will assist the clients with linking them to care, giving them information on where they can access care. There may be times where we may have a report on a provider may have a patient, client, who reported that they have prior diagnosis of HIV, syphilis. That provider may not have any health history. Again, here at DPH, we do have specialized staff who are able to reach out to other jurisdictions to perform record search to obtain information. There may be times these staff may be successful, and there are other times they are not unsuccessful. So here, we do have these staff here. At this point, I'm going to transfer over to Carlos Rivera, who is a DIS, and he will go to the stage of how he was very successful on locating a client and obtaining information to assist a community provider. Carlos, I'm turning it over to you. Thanks.
All right. Good afternoon, everyone. My name is Carlos Rodriguez. I'm a disease intervention specialist for the state of Connecticut Department of Public Health, and I've been in the sexual health field since 2016. I'm sorry, 2015. Now, let's dive right into the case. So we at DPH received an electronic lab report in which we received the ordering provider information and patient demographic information such as address, sex, gender, age, and a reactive TPPA result. This patient was a 31-year-old female with a reactive TPPA, and because the case met what we considered a high priority criteria due to the fact that this is a childbearing age female, the nurse consultant got involved and reached out to the ordering provider. She reached out to the ordering provider to try to get a little bit more background information. She wanted to know what was the reason for the test, to verify demographics, any other STD labs that were done, any treatment that was given, what was the diagnosis, any symptoms, and what was the patient's pregnancy status. The nurse consultant followed up with the provider, gathered this information, and during the conversation with the provider, it was found that the patient showed up to establish care, to establish prenatal care. So that's why the labs were done as part of the workup. It was also reported that the patient showed up at 20 weeks of pregnancy and recently arrived from Puerto Rico. And we're going to say that pregnancy, and we're going to call this child number 2. So they did the labs, they did RPR labs, came back negative. The TPPA came back positive. The patient reported prior syphilis history during her first pregnancy, and also told the provider that she was treated in Puerto Rico. Now, the nurse consultant informed me, and then I ended up following up with the Puerto Rico Department of Health just to verify this information. And during the conversation with the surveillance team in Puerto Rico, it was found that the patient had a syphilis history back in 2022. And at that time, she was diagnosed as a late latent and was not properly treated. Around that time in 2022 was when she gave birth to child number 1. And we did confirm that child number 1 was adequately treated with 10 days of IV penicillin, and that was back in September of 2022. Now, We did confirm that the patient did, just like she told the OBGYN about receiving treatment in August of 2023. We did confirm that she did receive a shot of bicillin. She also had an RPR of 1:1 and a reactive TBPA. That was all in Puerto Rico, right? But she never received full treatment back from 2022. So the treatment was not completed, and the patient was not seen again at the clinic in Puerto Rico, which is how a few months later she ended up showing up to the OBGYN to establish care. Around the time that she was in Puerto Rico for that test in August, they did not know about her pregnancy status. With that finding, I ended up actually reaching out to the pregnant mother. And during the conversation with the mother, what we call an interview, the mother reported a monogamous relationship with her spouse, who lives in the Dominican Republic, and claimed that that was the father of child number 1 and child number 2. But she does not know if he has been treated for syphilis and refused to provide the partner information. Um, After spending some time with the mother, reiterating the importance of treatment, educating her on the stages, the symptoms, I advised her that her OBGYN may be following up with her. I informed the nurse consultant of all my findings. The nurse consultant reached out to the OBGYN, and the OBGYN repeated labs and also decided to treat with 3 shots of bicillin. Now, the patient was confirmed that she went in for the first one, but no showed for the second one. The OBGYN ended up calling the nurse consultant to let her know that the patient did not show up for the second one. But the patient mentioned that she was admitted at a local hospital. Unfortunately, the OBGYN cannot confirm that. She tried checking, uh, she tried calling local hospital and could not verify that the patient was there. So she wanted assistance with this. So then the nurse consultant informed me of this, and I ended up making some phone calls, and that I ended up reviewing some hospital EMRs and managed to locate the mother at another local hospital. That information was relayed back to the OBGYN, and the OBGYN connected to that to the providers in that local hospital, in which they also did some labs in which the TBPA came back reactive, and they gave her a dose of bicillin at delivery. The fortunately enough, the second dose was still within the time frame, but the mother was discharged at 72 hours and was advised to follow up with her OBGYN for her third dose. The mom was lost to follow up, and the OBGYN confirmed that the patient never returned. Now, in regards to the baby that we called child number 2, baby number 2, the baby had a RPR non-reactive, had a CSF done, which showed high levels of protein, but the long bone X-ray came back normal. Now, although the baby received 3 days of PENG treatment, treatment was stopped once the long bone X-ray came back. And this right here, although is not a confirmed congenital syphilis case, we still consider this a probable case, right? Now, this scenario was brought up to show that DIS are there to help and collaborate with community providers to ensure that patients are notified, educated, and linked to care, with the emphasis of averting congenital syphilis. Also, to make providers aware that they can follow up with Puerto Rico Health Department or reach out to us to do out-of-state searches as long as it's U.S. territory. And although this is not a typical congenital syphilis case, not a confirmed congenital syphilis case, fortunately, the baby in this case is okay. But oftentimes, congenital syphilis cases can have severe negative effects, including death, which is why timely and consistent reporting is important. Thank you.
Thank you, Carlo, and outstanding work, both of you and your team. And this shows us the work that you do is so important, but it relies on the providers to alert you guys to make sure that you are onto it very soon. So that was great. Okay, it is my pleasure now to introduce Dr. Ian Michelow, sorry. Dr. Michelow is a professor of pediatrics at the UConn School of Medicine. He's the head of Division of Infectious Diseases and Immunology at CT Children's. He consults in pediatric infectious diseases and conducts related research. He has a background in medicine from South Africa, where he managed numerous babies with congenital syphilis. He's also had a fellowship, especially with Dr. Pablo Sanchez, who has been considered as a world authority on congenital syphilis. So I think together they have published some landmark work, including papers in New England Journal of Medicine. Which has informed the health policy. So I couldn't imagine a better expert to present to you today, Dr. Michelow, on congenital syphilis. So over to you.
Great. Thank you so much, Dr. Atra. And I want to just tell you that it's a great honor for me to have been invited to talk. And I particularly thank Dr. Kathy Sue and the others at the Connecticut Department of Health and Mass Department of Health for inviting me and for setting up this series, which is really phenomenal. It's very timely, very important. And I want to thank Arlene and Carlos for their illustration of the important work that they do. And I'm hoping that, you know, through this talk, we're going to be talking about congenital syphilis. We can tie in together what Carlos was saying, because you can see it gets very difficult at times, very subtle and a lot of nuances. And I know from the questions that I get, you know, on a weekly basis and my colleagues, that people can get, you know, easily confused about the management of babies with potential congenital syphilis. And there really are some challenges. The reason this is so topical, as I think this audience will know, is that this slide shows you the rate of syphilis, both primary and secondary in older people, as well as obviously the after effect is of newborns, both exposure and infection, has skyrocketed. And this is what we're looking at. These are CDC data over the last 10 years has gone up tenfold. And so we're dealing with a crisis. It really is a huge crisis nationally, and it's seen internationally as well, which I'm going to talk a little bit about. So the data I'm going to show, a lot of it's from the CDC. Some of it is from Kathy Sue, who shared some slides. Also from Dr. Lynn Sosa, who's the state epidemiologist of Connecticut Department of Health, and I really appreciate them sharing the slides with me. I don't have any disclosures, no financial disclosures or the use, talking about the use of any experimental agents or devices. But what I want to show you here is the organism. This is the cause of the problems we're dealing with. This little terrorist agent is, you can see it's screw-shaped, as the name suggests, spirochete. It's spiral, and it really can burrow into different tissues. And that's why syphilis can affect almost all bodies, all parts of the body, and it can get into places through the placenta, for example, into the CNS. And so it is critical to understand that part of the diagnosis is looking in places where it may be difficult to actually identify the organisms, and we're going to talk more about that. So you heard about a case from Carlos, and I'm going to just tell you another type of case, which is a lot more obvious. This is what we typically will see in the hospital. Often their second will be admitted to an ICU, but there's a wide range of presentations, and we'll talk about that as well. But in this is a real case, a 32-week female born by uncomplicated normal vaginal delivery and was transferred to the ICU because of her symptoms and signs. But so I'm going to highlight as I'm talking just the important points that we keep in mind in making a diagnosis of syphilis. The fact that this is a 32-weeker with signs and symptoms of disease and infection tells us and reminds us that a lot of these babies are born preterm for many reasons, including they have abnormalities of the placenta. And I'm going to show you some images. And this child was small for gestational age, so often they have intrauterine growth retardation, which results in them being born small. They can have, this child had generalized edema, which could be for a number of reasons. One is they could have low albumin, synthetic problems in the liver, or they may be anemic, and this child was clinically pale, turned out to be anemic, and that in the severe end of the spectrum can actually cause non-immune hydrops fetalis, and they can be extremely edematous with high output cardiac failure. This child was ecteric, which you could understand why. They get hepatitis, and they get a transaminitis, and they get hyperbilirubinemia. This child had mild respiratory distress, and that could be for a number of reasons, but partly because they can actually get pneumonitis because of the congenital syphilis. On exam, there were crackles to suggest there were problems. That could be fluid from the edema or infection directly. In this particular baby, the heart function was normal physiologically. The abdomen revealed a very large liver, which is not uncommon in these settings. The spleen was palpated, and you know that when you can feel the tip of a spleen, you know it's at least double the size of normal. And what's very classic in congenital syphilis is this desquamating rash over the trunk, particularly the palms and soles, which is pretty classic. And it's like a reddish coppery color, and I'll show you some images. And then this child also was not moving the right arm. And so, you know, when you see that, you're always going to be concerned, could there be inflammation in the bone? And in fact, there was a periostitis as well. So this is sort of encapsulates what we often see with congenital syphilis, but it's not always this obvious. And that's what we're going to be talking about. This is one of the headlines recently, and I'm sure you've seen similar types of headlines. This happened to be in the Washington Post in February. And the headline was, the numbers of syphilis in the US are the highest since the 1950s, according to the CDC. And they go and talk about what all the possible causes are. Clearly, lack of funding. And when the COVID epidemic hit, there was a lot of redirection of funding, and that definitely had an impact. But what I'm going to show you is, in fact, the numbers and the rates of syphilis in populations, not only babies, was already increasing quite significantly before COVID even hit. That, I think, just compounded the problem when it did hit. So lack of funding will lead to less screening, less treatment, less partner services, and all of this is clearly going to have an impact on the unborn child. Also, the opioid epidemic will lead to high-risk behaviors, not just for syphilis, but for all sexually transmitted infections. And that is clearly important to always think about other STIs when you're dealing with one particular infection, that's an STI. They've also noted there's a decrease in condom use. And what I'm going to show you is there are huge socioeconomic disparities. It affects people who are homeless, incarcerated, and this is clearly a huge problem. We need to get to the bottom of that to really address in a targeted fashion the people at greatest risk. And what we've realized more recently, and this is certainly was since April 2023, when the FDA declared a penicillin shortage, because Pfizer, which makes Bicillin, which is benzathine penicillin G, which is the long-acting benzathilin given intramuscularly, they said that they were unprepared for the huge increase in demand. And you know, you wonder, as numbers are going up, how that's even possible, but that's the given explanation. And when you look online, they say that some of these products will, they hope, come back earlier towards the end of 2024, but some formulations probably won't be available until sometime in early 2025. So we've got an important gap that we're dealing with right now, and I think we all feel the pain. We're constantly trying to find sources of Bicillin. The problem with babies is that the 600,000 units international unit formulation, in fact, is not being produced now, and so it's really not available. And that's the problem, because that's the formulation that we need to use for these for the newborns. Whether you can split doses, use the 1.2, the Pfizer won't give advice about how to do that. Some pharmacies are willing to do that, others are not. So it's really a problem. The FDA has made an allowance for importing a similar preparation from Europe called extensilin, but that requires a lot of hurdles. It's more difficult to mix. I've heard it's extremely expensive. And so that's not going to be just a simple alternative solution. I want to contextualize this topic in a few ways. One is just internationally. And if you look at this map, what you notice is in a lot of the sort of parts of the world around the center, the tropical areas and the less resource-rich areas have a huge problem. There's a scale on the left. You can see that's per 100,000 births. I mean, some of these are off the chart. You can see in Central Africa, and there's a big hole in Central Democratic Republic of the Congo. I don't necessarily believe that that's the case, that they have low rates. I think, there's a constant war being going on there, and I think that's just lack of data. And I think you could argue that that's for other countries as well. But, you can see it throughout South America, specifically Brazil. And if you look at the numbers in the US, which I'll hone in on, it's not as good as it should be by any stretch. And so that is obviously concerning, but you can see this is an international problem and very serious. If you look back over the years, and clearly in the 1940s, before penicillin was discovered, the rates were through the roof. I mean, over 600 per 100,000 live births, that's hard to even get your head around. And with the use of penicillin and education, the numbers came down. And they were really doing well. People in the US thought, oh, this disease is combated. We don't have to worry about this in the 80s. And then early 1990 came around. And there was a huge problem at that point, both in adults and in newborns. And some of the research that I did with Dr. Pablo Sanchez was actually dating back to that time when there were so many babies being born with syphilis. And they got that under control via various means. And now what we're dealing with, since you can see 2012 or so, these numbers are going up, and they're going up logarithmically, which is why it's so concerning. I'm going to hone in on those dates. And so what you can see are these are US trends data from the CDC up till 2021. If you look at the blue bars, what you can see is the numbers of congenital syphilis cases, and so those numbers on the left axis, on the y-axis on the left. And then in the dark black line, you can see the rates of primary and secondary syphilis, which would be women in the reproductive age group. And those rates are also increasing at a staggering rate. So if you look at the numbers, the rate of increase from 2012 to 2021 has gone up over 700%, which is mind-boggling. And so currently, we're dealing with 1 in 1,300 live births, babies are being affected. And these numbers are actually getting worse because the numbers in 2022 have actually gone up even more. I just wanted to show, for example, where, if you look at where COVID started in 2020, the numbers have already been going up before that time. So this is predated COVID, but that obviously compounded the problems. And this at a glance, you can see that we've got a serious problem here. If you look at these data in 2021, and this is now stratified by different populations, and you can see that the rates of congenital syphilis per 100,000 is absolutely uneven. There's clearly disparities in different groups of people. And even though the numbers may not be the same, if you look at the ends of the bars, they give the number of cases. The numbers of cases in certain groups are not as high as other groups. But if you look at the rates based on their population, I mean, it is clearly a huge problem. And this refers to American Indian or Native, Alaska Native in the top. And then you can see other groups which are hugely affected. Native Hawaiian, other Pacific Islanders. You can see Blacks, African Americans, and Hispanics. So this is a problem that we have to keep in mind. And at every step of the process, we have to be targeting those at greatest risk and educating people and treating them, bringing them into management, and follow-up is going to be critically important. These, thankfully, we have to thank Dr. Sosa. These are the rates, specifically in Connecticut from 2012 to 2022. And what's reported here, these are the actual numbers, but what you can see is there's a staggering increase, 600% since 2015. And what they found, maternal risk factors are either little or no prenatal care, polysubstance abuse, which comes up again and again, and housing instability. So markers of poverty and social instability. And what we have to keep in mind is that this mother-infant dyad are inextricably linked. That the only way to prevent congenital syphilis is to prevent, test, and treat women who are pregnant and have syphilis. I mean, that's really the bottom line. They go hand in hand. And so that's recognizing women who are infected at hopefully an early stage as possible in their pregnancy, because that's also very important. I'm going to show you. And these are the types of findings. This is primary syphilis. On the right, where you can see a chancre, which is painless. You can see the typical rash involving the palms and soles, maculopapular rash. And you get also around the mouth, you can get these sort of lesions, which are called Regades. And so these are some of the classic findings, but they can be missed. And that's also part of the problem. And they can be diagnosed late. People, in pregnancy can get infected late. So there's so many different reasons why babies can get infected. And this is just one sort of image to show you over time, over the last number of years, what the actual missed opportunities are among women who are delivering babies with congenital syphilis. Looking back, they can see what actually happened. And on the right, you can see here that there are many different scenarios, but a lot of them are failure of our health system. No timely prenatal care and no timely syphilis testing was a huge chunk. Or there was timely syphilis diagnosis, but no adequate maternal treatment, which is very, very concerning. If they're in our system, unfortunately, that should not be happening. But we understand there are a lot of reasons why this does happen. Then late identification of seroconversion, that can be late infection or just presenting late to care, and no timely syphilis testing despite timely prenatal care. And those babies who are infected despite getting optimal care can still happen. And that's it's a low number, but we have to keep that in mind, that syphilis can affect newborn babies, even though we think mothers have been adequately screened and treated. We're just going to keep that in mind, because the treatment may not be as adequate as we think. And I think Carlos sort of made that point, that people thought that maybe it was adequate. When you really start digging into this, and we need these DIS specialists, you find out that in fact, it's like, things happen and things are missed, and you need people like Carlos to be in the field and really digging in and dealing with the practitioners to make sure that this is not missed. So if you then think about, well, what are the time points that fetuses can get infected? It's really any time in pregnancy. And any time, really what's been shown from about 9 weeks of gestation and onwards. The greatest risk for transmission is primary or secondary syphilis, and that's up to 100% transmission, so extremely high. And you really want to pick up these mothers who are infected as early as possible. The transmission, if mothers have early latent syphilis, that means they've been diagnosed within the previous 1 year, but they haven't been adequately treated. The risk of transmission is still very high, but lower. And then if mothers were diagnosed more than a year ago, but still not treated, that's called late latent syphilis. And the transmission is lower, but not zero. And that's what's important. And that's when you need those 3 doses of bicillin in the mothers. Otherwise, they're not adequately treated and they can still transmit to their babies. Now, as the gestational age increases, when the mother is infected, the risk of transmission increases. So if they're towards the time of full term and a mother gets infected, that's a great risk to the baby. Babies can also get infected perinatally if they come into contact with genital lesions. And then the huge problem here is that babies, fetuses may not make it to delivery. And that's a real disaster, that up to 40% of pregnancies in which mothers are infected, they can have spontaneous abortions, stillbirths, and perinatal deaths. And that's what Carlos said. The bottom line is these babies can die from syphilis. That's what we're dealing with. We cannot afford to miss these babies. In 2021, the STI guidelines were updated. And within that, there's syphilis guidelines. A lot of the things were reiterated from before. There are some changes. I'm just going to highlight a few of the issues that are really important. But as we all know, the only treatment that is considered effective is benzathine penicillin G. And that's for people who are pregnant. And whether you give 1 dose or more than 1 dose depends on the stage of infection. So if it's primary, secondary, or early latent syphilis, if you look at the guidelines, they say 1 dose of benzathine penicillin. But I and colleagues and Dr. Su and others actually think that a second dose may be appropriate. And that would be administered 1 week after the initial dose in these situations, because what can happen is that you can have an early infection and mothers are heavily infected with very high counts of treponines. And one dose may just not be enough if, for example, and there's some data to show this, that the levels of the penicillin actually can decline, and to the point where you're not getting it sufficiently above the minimum concentration that you need to kill the spirochetes. Now, the CDC guidelines still are endorsing 1 dose. And if you look at the data, why it may make sense to give 2 doses, there's an early study out of UT Southwestern, George Wendell and colleagues, which is where Pablo Sanchez was working. And they actually tracked the concentrations of penicillin in these situations in mothers and in babies, in amniotic fluid. And they showed that by day 7, that something like up to 50% of mothers' levels were not high enough to be sustained long enough, as long as you need it to be. But this didn't really translate into clinical failures, and that's sort of where some of the controversies come up. But we can take those questions at the end. And then the other thing is, if the treatment is delayed, so for latent syphilis where you need 3 weekly doses of benzathine penicillin, if any dose, any interval between 2 doses delayed more than 9 days, you've got to start at the beginning again. And that's what Carlos was talking about. If a mother's lost to follow-up and you can't get them within that 9 days, that doesn't count. You have to go back to the beginning. Otherwise, it's going to be ineffective. Now, how do we know if the treatment is effective? Well, what we can do and what should be done is tracking the non-treponemal titers. These are the RPR and the VDRL. And we should be tracking them, OBs should be tracking them over time after treatment to make sure they go down 4-fold. But what this image shows you, and this is from a good paper in Clinical Infectious Disease in 2015, is that S stands for secondary syphilis, P stands for primary. And you can see that as time goes on the x-axis, it will go down. And you can figure out how it goes, from the beginning titer to 4-fold decrease. It takes a certain amount of time. Now you can imagine that if a mother is being treated towards the end of pregnancy, you're not going to have enough time before delivery necessarily to see this decline. Now that's where some of the difficulties come in, because that doesn't mean they've failed therapy. It just means you haven't had enough time to track it. But there's still open questions about, could that baby still be at risk? And that's why we do not take any chances, that we always err on the side of caution for newborns because of the great risk of long-term problems in these babies. And so the guidelines that we'll go through are really very cautious, and they do not leave room for error, that they err on the side of caution, and we treat rather than not treat in babies where there's any possible question that could there still be a risk for the baby. And that leads to over-treatment sometimes, but I think that's accepted, that we can't risk loss to follow-up, because that's what you need. You need to follow babies up to make sure that their titers come down. We'll go through that. Now, what can you do in pregnancy for monitoring? Well, ultrasounds, if you diagnose a mother who's infected and you do an ultrasound and you see placentamegaly and other signs of infection, it's important after treatment to keep on monitoring to make sure there is a good response. You can see fetal hepatomegaly, you can see hydrops, polyhydramnios, and there's good studies to show how long it takes for these to resolve over weeks to make sure that the treatment has been effective. Babies, fetuses can be anemic, and there are ways that you can measure that in ultrasounds using peak flow, measuring peak flow in the middle cerebral artery. So there are many ways that before even the baby's been born to see and monitor whether they're actually responding to maternal treatment. What are the treatments? I've already touched on this: spontaneous abortion, stillbirth, preterm delivery, intrauterine growth retardation, congenital infection, as we're going to be talking about, and infant mortality, which is important. Now, syphilis has been called the great imitator, and this is very true for babies as well. And if this is a great image from an article from January by Irene Stafford in Texas and her colleagues, looking at all the clinical, hematologic, and radiographic features. And what it goes through is literally organ by organ about what you can see. And you can just see, at a glance, it affects the CNS system with aseptic meningitis. It affects the eyes. You get this rhinitis, which I'll show you images of. You get big livers and spleens. You get pneumonia. You get bone involvement. You get skin rashes. And you can get, ultrasound findings, and then laboratory findings, which is, a whole range of things, from anemia to increased CSF white cell counts, elevated CSF protein, increased ALT, and bilirubin levels, which are elevated. So, and babies don't have to present with all of these, and babies can be asymptomatic. And I'm going to talk about that, because you don't have to see all of these. And that's what makes the diagnosis very challenging sometimes. I've got a few images I'm going to go through quickly, just to give you a sense. This is this copper red maculopapular rash that I'm talking about, that you can see in newborns. It's not just the postnatal type of mature, desquamation that you can see in post-mature babies. So babies can be small, they can be premature or SGA, and they can have this peeling because of the infection. And you can see here as well, it can be in different parts of the body. Here, if it's a wet type of lesion, it's a deep type of infection, this would be teeming with spirochetes. And so, you need to be aware of that. When you're dealing with any babies, you should be wearing gloves, because this can spread from these lesions. And you can see perianal as well, some involvement over there. This is the so-called snuffles. This is serous, it can be purulent, it can be bloody. There's some bloody discharge over there. And again, this is teeming with spirochetes. They can get this dry cracking around the lips in different, called rhagades. And what you can see here, there's on the right-hand side, there's some blood coming out of the nostril there. And if you look carefully, you can see some swelling at the wrist and the elbow. And that is showing you that there's actually bone involvement in this baby as well. And what you can see here, these are what we call snail track ulcers. These are a mucositis involved in babies who can be involved, and you can see some rash in the skin as well. What these images on the left are trying to show, they've marked out with a pen the enlargement of the liver, as well as the spleen and the far flank area, and the X-ray just shows you that the liver and the spleen, the liver's enlarged there. Now, what you can see, this baby is holding the arm sort of arm splintered. You can't see that, but it's in the text, it says that. And then they don't move their arms because of pain, because of their periostitis. They can, they get osteomyelitis from this as well. What you can see here are showing images of pneumonia. It can be very subtle. It's called pneumonia alba. Alba is a Latin word for white, because of the histopathological findings of what they see under the microscope. And so actually morphologically, macroscopically, and they can have very severe lung respiratory disease as well. They don't all have this, but it is pretty common in about 70% of symptomatic babies to have bone involvement. And you can see here this metaphysitis. It's very classic when the proximal part of the tibia is involved. That's called the Wimberger sign. I've seen that numerous times, very, very common. And you can also see pathological fractures here on the right-hand side, where you can see callus formation because the bone is starting to heal. This is actually a real, a baby that we saw. This is about a year ago. This baby was extremely sick, but it really presented like sepsis. And everyone thought it was bacterial or viral sepsis, not necessarily syphilis. But then it became obvious, and we can see as petechiae, you can see the skin rash. And this baby had lung disease, had pneumonia, needed oxygen support. And we went back. Dr. Justin Radoff was involved with this case because he's one of the syphilis experts with Dr. Juan Salazar, and asked the question, well, what does the placenta look like? And we did go back, and believe it or not, it's incredible to see this. And this is more common than we realize. And that's why placentas are really important to keep in mind and to think about. We went back and look at this under 400 times magnification. This is the umbilical cord vein. And we actually got these images. What I've circled are the spirochetes. And the one on the far right with the thicker red circle, that is a spirochete actually crossing the endothelium of the blood vessel to the right where the blood is. That's the lumen of the blood vessel in the umbilical cord. We actually caught it in the act of actually going into the baby's circulation, which is absolutely remarkable. Now, the timing of clinical presentation. So a lot of babies are actually asymptomatic at birth. And that's very important to keep in mind. You're not going to see the case where they tell you, I'm a baby and I've got syphilis. That is just not always the situation. And so we have to have a very high index of suspicion. That's where testing is so critically important. In 2/3 of cases, of untreated cases, the syphilis begins, signs can appear at 3 to 8 weeks of life, so you can miss it at the time of birth. But usually all symptoms have developed by 3 months of age. You can get late congenital syphilis, which is after 2 years of age. The evaluation, we've spoken about the RPR in babies, not the treponema test, because that will cross from the mother. You want to get it not from the cord, because you can get contamination from the mother, and Wharton's jelly can inhibit the test. And we do all the other tests, the CBC, the LFTs. Doing a spinal tap is important to see if there is involvement. And the reason is because that may help you, really prioritize those who've got CNS involvement for long-term follow-up. Not all babies have CNS involvement, but a lot of them do. Long bone x-rays, placental pathology, as I said, and checking the mothers for other infectious diseases. I'm going to briefly just talk about this. This was a paper that I published with Dr. Pablo Sanchez and other experts in syphilis. And this was looking at babies with congenital neurosyphilis or aseptic meningitis. And what we found is that out of 76 newborns of mothers who had not been treated, 22% had neurosyphilis, which is a huge number. And we proved this by, in fact, taking CSF and infecting rabbits, which is the standard of making sure that there is spirochetes that are viable. And then 16 of those 17 were diagnosed clinically by all the things we usually do, but one was not. And that's important to realize. We don't always find these babies just on conventional labs. That's why we're so cautious. And the CSF tests were not good in 3 of 17. So in 18% of babies, we missed the neurologic involvement. So that's really important to keep in mind. That's why these guidelines are so conservative. We turn to the CDC for guidance on evaluation and treatment of newborns. The Red Book also has a chapter on this, which is based on this. And they have 4 scenarios: confirmed or highly probable, possible, and congenital syphilis that's less likely and unlikely. And they go through all the tests through each of these. And this can cause a little bit of confusion for some people at times. And the CDC says you can either use the traditional method of using the RPR testing first in mothers, or the reverse algorithm where you first do a treponema specific test, which is an EIA, which is a screening test. Now, what is known is that the traditional algorithm can be a little bit less sensitive, more false negatives for the early or late latent syphilis, whereas the reverse algorithm can be a little bit less specific. But overall, they agree extremely well. And the CDC says that both algorithms are accessible. The reason we use the reverse is because it can be automated and it's easier for busy labs. This is an algorithm which Dr. Sanchez and I have published. It's based on the Red Book, although there are a few differences. And instead of sort of going through the 4 scenarios, this just is a very practical approach. And I'm not going to go through the traditional because most labs now are actually using the reverse algorithm. And the reverse algorithm starts with a treponema specific assay. It can be an ELISA enzyme immunoassay or complement-related test or combined IgG and IgM. And then based on that, you would then do the next step. If it's reactive, you go to the next step, which is the RPR or the VDRL. And if it's non-reactive, then you go to discordance, you go to disagreement, and therefore you need to do the next step, which is the third step for a tiebreaker. And depending on what you find, if it's non-reactive, you're done. That's a false positive reaction. But if that the third step, which is the treponema specific test, PA stands for particle agglutination. If that's reactive, then you move on and you're concerned, then the mother has syphilis. Now, if the screening test, the EIA, is positive and the maternal RPR is positive with VDRL, that's done. The mother has syphilis. And then you move on to the next step, which is testing the baby. Okay. Now, if the baby has the RPR that is less than 4 times maternal, we're going to move on to that because those are all the different scenarios. Has the mother been adequately treated or not? Whereas if the infant's RPR is more than or equal to 4 times the mother's, that's clear cut. The baby has confirmed or very probable, highly probable congenital syphilis. So the next slide shows that. On the far right, you do, the infant exam. And if that's abnormal, you do the evaluation and treatment. So I'll just go back. So if the infant's RPR is greater than or equal to 4 times the mother's, and you go to the next slide, you evaluate, you do the full evaluation and treatment. Now, if the infant's RPR is less than 4 times mother's, then you've got these two scenarios. You've either got the infant's exam is normal or the infant's exam is abnormal. If it's abnormal, it's easy. The baby has congenital syphilis, you do the full evaluation and the treatment. And the treatment one is the 10 days of benzathine penicillin, okay, aqueous, which is 10 days IV. Now, it gets a little bit more complicated on the left. If the infant's exam is normal, you divide it into 3 scenarios. One is if the mother's treatment was fully treated and adequately treated before pregnancy, that's it. No evaluation or treatment. The mother's fully treated and there's nothing else to do. And that agrees with the CDC's recommendation, the Red Book. The next scenario over to the right, if the mother's treatment was during pregnancy more than 40 days before delivery and no evidence of reinfection, then no evaluation is needed. And the CDC and the Red Book would say you can follow up and see that their titers decrease. And you know, if that's the case, don't worry about it. If it's not the case, you treat the baby. What we say here is go ahead and give a dose of bicillin, because babies can be lost to follow-up. That's just IM. That's a single dose of benzathine penicillin. The next one to the right is maternal treatments, none or undocumented or inadequate, less than 30 days, or non-penicillin drug, or evidence of maternal reinfection. Well, in most instances, if the infant's RPR is reactive, you have to evaluate that baby, and that includes the whole works, CSF, X-rays, blood work. And if that's normal, you just give benzathine penicillin. If it's abnormal, then you do 10 days of treatment. On the other hand, if the baby's RPR is non-reactive, completely non-reactive, in this instance, in this algorithm, what we're saying is you don't need to do evaluation, just treat them with bicillin, because there are no reported cases of failure and recurrence or late manifestations of syphilis if they've been treated for syphilis with bicillin in this setting. Whereas the Red Book would say you do evaluate everybody. That's the only difference there. And I just want to highlight and remind you that it's a reportable disease within 12 hours by fax or mail. You can get this form online. Treatment, as we said, for confirmed or highly probable, always 10 days penicillin. Can't use anything else. If there's more than 1 day missed, you've got to restart the entire course. And there's no data to support the use of ampicillin. It has to be penicillin G. And as I mentioned, if a diagnosis is missed, whether the baby is asymptomatic or symptomatic and a baby has not been treated, late congenital syphilis, by definition, occurs after 2 years of age, and it can affect all the same body systems: bones, joints, teeth, eyes, skin, and then much later on, years later, that's when you can get these other findings which you see in adults: keratitis, deafness, abnormal teeth that you can see there, frontal bossing, bowing, molars, and some other effects as well. Important to know that breastfeeding, it does not transmit syphilis, but it can, if there's a chancre on the breast, obviously that's through direct contact, that can happen. Follow-up is absolutely critical. No baby should be discharged from the hospital without the mother's syphilis result and a plan to follow up. You need to follow up babies who have been diagnosed with syphilis at 2, 4, 6, and 12 months, and repeat the RPR every 2 to 3 months until it's non-reactive. And it should decrease by 3 months, and it should be non-reactive by 6 months. And if it's not, you have to consider there may be failure therapy, repeating the workup, and maybe treating again. And in the last few seconds, I just want to tell you what's just been announced. This was a release of April 18th by the American College of Obstetrics and Gynecologists. And this now supersedes the CDC recognition. And they're saying that all pregnant individuals should be screened for syphilis at not what the CDC says, at least once during pregnancy, but at the first prenatal care visit. They should be rescreened during the 3rd trimester and again at birth. Whereas the CDC still says at least once during pregnancy, and if high risk, then at delivery. And it's not just, it's high risk individuals and high risk states. So it depends on really where you're practicing. But I've had the opportunity to speak to OB at Hartford Healthcare, and they are actually instituting this. So this is going to be a new standard of care. And I think it's important for all practitioners to know, where they're working, what the OBs are going to be doing in their centers. And I would say advocate to do this, because I think it's really important. My acknowledgements, as I've said before, Dr. Pablo Sanchez has been an incredible advisor and mentor to me. He's really the expert, the world authority on congenital syphilis. Dr. Sosa and Dr. Su at the Departments of Health in their respective states, who are leaders in this. And I thank them very much for their input and continued assistance. And my other mentors, Dr. Juan Salazar, my chair, and Dr. Justin Radoff at UConn, who are also really world authorities in syphilis, not only congenital syphilis, but they're working on syphilis vaccines and doing just phenomenal work, and PhDs in their lab as well. So I just want to end there and thank you all for your time, and happy to take questions. And also just mention that Dr. Sue's in our audience, and she's an absolute expert in all of this stuff in pregnancy. So I'm going to lean on her if there are any questions about pregnancy.
Great, thank you very much, Professor Michelow. Any questions? While I think our coordinator, Janine Dyer, if you can share the CME info, while we can also address any questions. The chat, I think we kind of answered. I don't see anything outstanding in the chat, but feel free to unmute yourself and ask.
Hi, everyone.
Yeah.
I'm going to just share the continuing education credit information here, as you can see on the slide. So we streamlined the process to simplify it as best we could, just like the registration process. So at the end of the series, we'll share the link to complete the post-series evaluation. And then you can claim the credit commensurate with the extent of your participation in the series. Thank you.
Great, thank you. And any question or comment? Okay, a positive review there. That's great. Yep, go ahead.
Maybe I could ask Dr. Su, because we've been talking about this, going back and forth about, whether mothers who are pregnant should be getting, if it's not late latent, so early latent or primary secondary, should they be getting a second dose? And I know that Dr. Su's got some fairly strong feelings about that. And maybe there's some OBs in the audience. Maybe, Amit, you've got some experience and some opinions. But I'm a little bit in two minds. I have no control of this, as I'm at the receiving end. But OBs will say to us, will say to me, like, what's your opinion? And I'd love to hear other people's opinion, honestly.
Yeah,
I'd love to hear what's been happening out in practice.
Yeah, I'm not OB. We rarely interact because my panel is mostly on the MSM group. But yeah, anyone in the audience want to chime in?
At Hartford Healthcare, I don't think they're giving 2 doses. And when I suggested, they said, well, what's the data for it? And Kathy sent some papers for me to look at. And it's it's a little bit, Kathy, you can comment on this. It's not clinical outcomes data. It's just, in vitro pharmacokinetics data. So, so you could say, well, how does that truly relate to outcomes? And I don't have the answer for that. I haven't seen failures specifically of 1 dose, but when I spoke to Pablo Sanchez about this, he says, no, if a mother's got a very, severe infection and it's early stage, he definitely recommends 2 doses for the mothers, because he knows, he thinks it can fail.
Pretty much when you've polled any of us out in practice, we do 2 doses, even in the absence of clinical outcomes or trials on this matter, because there will never specifically be a trial upon this matter, most likely. And we're basing it entirely, just as you say, on a very tiny anecdotal case series of the way penicillin during pregnancy is distributed and eliminated probably a little bit more quickly than it is when you are not pregnant. So it makes us all very nervous that you don't have a full 7 days or beyond of coverage with an extended penicillin that stays on board for all that time period, especially if you start with a higher bacterial burden, as you say. Yeah. Secondary syphilis.
And then Kathy, maybe you can comment with your experience in Massachusetts. What are people doing about splitting the doses? Because if we can't get the 600,000 units dose for newborn babies, this is going to represent a problem. If it doesn't come back online until early 25, we're all going to have this problem. So maybe you could just make a comment about that. What can people do for newborns?
It only comes into play for those that are getting the IM dose. To be clear, the aqueous formulation of penicillin, the IV formulation that we use to treat, is still available. That people haven't gotten into a shortage situation. It's the pre-filled syringe that's designed for smaller people, and the dosing is 50,000 units per kilo body weight, that Pfizer is not making in order to make more of the demanded adult formulations. So they've really had to sort of stop certain production chains to scale up on the 1.2 and the 2.4 million unit versions. So it's a bit of a puzzle. Dr. Michelow, as you know, different pharmacies, different hospital pharmacies are running into different issues. And we've honestly not heard about somebody running out to the extent, but they should have already. It might possibly have expired. And I don't know why we haven't heard this signal yet in Massachusetts. There is a replacement though. So unlike for pregnant women who only can get Bicillin, are supposed to be desensitized with Bicillin or penicillin to make sure that they get Bicillin specifically during pregnancy to treat syphilis. An infant could get the aqueous penicillin for a period of time. They could get that. There is also the option of course, replacement for orals for other kids, like the kids with strep or acute rheumatic fever, that you want to prophylax from further group A strep infections. They could get oral dosing, which of course is never as good. You have to be compliant. You have to remember it, but there are alternatives, whereas there are no alternatives for pregnant women. And that, I'm guessing, is how people are circumventing the concern about the lack of the 600,000 pre-filled syringe.
Yeah, thanks. There was a question from Dr. Les Welkoff. He's a neonatologist.